The majority of the patients that we will use PRRT tends to be second line and beyond. And when we put in context all the treatments that we have, I think especially for the mid-gut tumors, PRRT is definitely the winner when it comes to second line treatments. It's an exciting time to be a doctor taking care of neuroendocrine tumors.
This podcast is for healthcare professionals only and is supported by an independent educational grant from ITM.
Hello, everyone. Welcome back to the Oncology Brothers podcast. I'm Rohit Gosain, along with my brother and co-host Rahul Gosain, with our goal to keep our community oncologists up to date in the world of cancer. Today, we are going to be talking about NETs, neuroendocrine tumors. Briefly, we will touch on the treatment landscape, but the focus of the discussion will be on radioligand therapies available and how to best use them.
To touch on this, we're excited to welcome Drs. Heloisa Soares, a medical oncologist focusing on neuroendocrine tumors, and Dr. Ken Herrmann, a nuclear medicine physician from Europe. Ken, Eliza, welcome.
Thank you.
Thank you. Thank you for having us.
Thanks so much for joining us. Before we go any further, let's set the stage for neuroendocrine tumors, where we stand from the treatment landscape. We divide them basically into functional versus non-functional, where often the non-functional ones were rather asymptomatic, but the active treatment options that are available for functional NETs are somatostatin analogs. We recently saw approval of cabozantinib, and we also have radioligand therapy, such as PRRT. And also, for high-grade tumors, we take this treatment from small cell lung cancer. That is the chemo option. Before we dive into more in the treatment world, let's touch on the imaging modality, where octreotide scans used to be our thing, but now we have been relying heavily on gallium dotatate scan. Heloisa, I'll start off with you here. Could you start us off where do you get this gallium dotatate scan? Is it at initial diagnosis or rather progression? And if so, what's exactly the utility of it? And importantly, outside clinical trial, are there radio tracers that are available that you rely in your practice?
I think we use the imaging studies in combination with the cross-sectional studies. So typically I will have my patient have assuming it's a GI gap net, I'll have my patient having the MRI of abdomen and pelvis with contrast, or a CT of abdomen and pelvis with the arterial phase of this portion of the liver to really be able to identify the tumors. In addition to that, at diagnosis, I will definitely try to get a somatostatin receptor functional imaging to help and complement the workup and plan for my patients. And yes, we have the gallium-68 dotatate PET CTs. We can also use copper-64 that's also available in the US. So we have these two radioisotopes that we can use. I'll typically use at the time of diagnosis. Typically, if the patient is going for surgery, I certainly try to have also a dotatate PET CT, given that the sensitivity of the dotatate is much higher, tends to be up to 90%. So it's excellent to try to identify what we call quote unquote occult disease.
Thanks for getting us started. You brought up dotatate, be it gallium or copper. In the community settings, if I don't have one or the other available, am I missing out on some critical information? Is one more sensitive than the other?
No, absolutely not. I think there's a slightly difference in sensitivity and background noise depending on which radioisotope you use. But in general, the concept you can use one or the other, and you are not missing in quality or information choosing one over the other.
And Ken, if the disease is progressing on somatostatin analogs, Rohit brought up a few treatment options: everolimus, cabozantinib, and PRRT. For PRRT, we often get nuclear medicine or radiation oncologist on board. In a patient that has dotatate positive disease, and you're seeing this patient to consider PRRT, what do we have to support this practice? And in real life, what does that conversation look like for that patient in front of you?
So first of all, I want to say that what Heloisa alluded to is, and indeed, there's a lot of very, very good data to underline that somatostatin 2 receptor imaging with PET is better than anything else. Nevertheless, I think it's very important that we actually perform this imaging technology always in addition with the contrast enhanced CT. I think it's very important. why do I actually don't answer your question is because this is actually leading me to my answer. We need to know that the lesions which are disease dominating are somatostatin 2 receptor positive. And for this, we need the additional information from the CT plus the PET information. Right. And in these patients, actually, we really discuss, depending on the previous treatment, if the patients are candidates for PRRT. Now, we know that there are different grades. Obviously, for well-differentiated tumors less than Ki-67 of 20%, we have, I think, quite solid data. We can also discuss a bit later about patients who have a more aggressive pattern. But overall, right now in daily routine, we really focus on the patients who have a Ki-67 less than 20%, who have progressed to cold somatostatin receptor analogs, and where we are discussing the next line of treatment. And we actually usually perform this in MDT, where we bring all together the different level of information, and also something which we also have to discuss, how quickly is the disease evolving, because PRRT is not a therapy which you treat one time and you will see a response within 1 or 2 days. It's a treatment which needs time to be efficient.
Thanks so much for touching on that, Ken. And we will be diving into the world of MDT, multidisciplinary approach, because again, oncology in general is a team sport, but there are some cancers where this team sport applies more than others, and neuroendocrine tumor is certainly part of that. Heloisa, with regards to the available treatment options, now, where do you use PRRT? Is it upfront or relapse refractory in your settings? And also, if you could touch on any role of this in high grade as well.
We do have data from the NETTER-2 that shows that in patients with more aggressive disease within the well-differentiated GAP-NET world, there is a role for first-line treatment with PRRT. Having said that, the majority of the patients that we will use PRRT tends to be second line and beyond. And when we put in context all the treatments that we have, I think especially for the mid-gut tumors, PRRT is definitely the winner when it comes to second-line treatments. We had the NETTER-1 study that showed the use of lutetium-177 versus 60 milligrams of octreotide, and then show that PRRT was superior in terms of progression-free survival. And just this year, in March, we had a presentation during the European Neuroendocrine Society meeting that showed via the COMPETE study that lutetium-177 DOTATOC was superior to everolimus, and they use the active comparator of everolimus. So, and that really, to me, consolidated the role of PRRT, particularly in second line. I think the decision of first line is a little bit more complex, even though the data was positive. Do you miss too much in still using a somatostatin analog? We have the data in progression-free survival benefit, but we don't have overall survival. So I think definitely for the higher grade tumors is a little bit more of a discussion. And in terms of well-differentiated G3 tumors, because we don't have this population of patients, we potentially see the benefit as well. It's just a question as how fast the tumor is progressing, and do we have to start with something else sooner, because sometimes depending where you are, it might take time to set up PRRT. And there's lots of nuances that, Ken and I can discuss as well about the decision for the higher grade tumors.
One thing important here is the logistics. It's not just saying, all right, this patient's going to get PRRT, off you go. That coordination takes a while. Ken, coming back to you, setting that right expectation with the patients as well, saying you're not going to see a response within a day or two. It's not one and done. So these are the things that we have to keep in mind. Ken, is your practice any different in Europe in terms of sequencing? Are you relying on this upfront? Are you saving PRRT for refractory relapse disease?
I had the pleasure to work actually on both sides of the continent. So, and I have to say that overall, it's not that different. The difference are rather subtle, to be honest. So regarding the clinical standard, the data is the same in Europe as in the US, right? Pretty much what Heloisa said. We have very, very compelling data for second line in midgut. I think also now with compete also with PNETs in very differentiated ones. NETTER-2 is very interesting data, right? I'm very curious to see what Compose is doing to give us. But we also have to be very honest. that bring it really into first line probably needs a little bit more than just what we have seen so far in the higher grade tumors. Now, regarding the practice, one of the big differences, I think, is that in the US, it's an outpatient treatment. Yes. So you really get the treatment and the patient is sent home the same day, whereas, for example, in Germany, we like to keep the patients 2 days with us.
Ken, keeping that patient in mind that's getting PRRT under your care, what are some of the side effects that we see with this modality? Any clinical pearls to manage this? And is it safe for renal dysfunction? What are some of the contraindications?
Then the most important toxicity depends on the angle. If you talk to the patient, actually for them, for us, the most important is that they really do not like nausea, which is actually not associated directly to the treatment itself, but rather to the kidney protection, these amino acids which are infused. So these are usually the thing the patients complain the most about. When you talk to the regulators, they actually worry the most about the kidney dose and the potential kidney toxicity, even so we know now that we have very long-term data showing that this is actually very, very tolerated, even regarding the kidney toxicity. And the third one is then the clinical angle, and the clinical angle is something in the long term we are the most concerned about is actually the bone marrow function. So bone marrow function and potential secondary malignancies, not very frequent, but still something you need to worry about. So in summary, 3 different toxicities from 3 different angles: nausea for the patient, kidney toxicity for the regulator, and for me in the clinic, it's a bone marrow.
And with regards to tying in with the bone marrow aspect, Heloisa, I'll go to you for this one, where bone marrow suppression is certainly a concern. Any risk of, when you're talking about secondary malignancies, Ken, Heloisa, have you seen any MDS or AML it being transformed, any role of bone marrow biopsies, and how do you go about that?
Absolutely. And that's the big conversation that I have with my patients in clinic is about this risk of MDS and acute leukemia that might develop, which typically on the phase 3 studies has been between 2 to 3%. Okay. And then I think there is more emerging evidence showing that if you were at some point also having your treatment journey, the patient having the treatment journey, alkaline agent, chemotherapy, that risk of acute leukemia or MDS might increase. The percentage of them might increase. We don't have prospective data, but there's some retrospective studies. And one of the highest that I've seen has been from the Moffitt group with John Strasberg, that when he looked at the patients that he had in clinic that received temozolomide at some point and PRRT at some point, it was up to like 10%, right? So that's a big conversation with the patients, particularly those that are going to be using chemotherapy. The clear example here is the patients with pancreatic neuroendocrine tumors where capecitabine and temozolomide is very used. So that's the big conversation. The timing of when the leukemia or the MDS will happen is a little bit all over the place right now. So it can be right away or right away after finishing treatment, or it might take some years. So to answer your question about bone marrow biopsies, I typically would expect that the bone marrow will recover because we see some decrease sometimes in the counts for a while. But typically, if they don't fully recover by a year, that's when I start discussing bone marrow biopsy. Obviously, if before that there is some concerns, we see blasts in the CBC, in the peripheral smear, that's a different story. But if it's just that the counts are not recovering, I'll wait up to a year before I refer to my colleagues in hematology for additional workup and potentially a bone marrow biopsy.
I really want to emphasize what Heloisa just said, right? I mean, literature gives you MDS rates between 1 to 10%. And I think there's one very nice data set I want to mention, the long-term follow-up of NETA-1, really 5-year follow-up. And there, to be honest, as Heloisa correctly mentioned, the MDS rate more on the lower end of the spectrum, so more like in the 2% rate. So that's why I think it's very important to mention. Of course, also the additional use of chemotherapy would, of course, increase that.
So again, coming back to that patient education, setting that right expectation on our end as practicing physicians, we have to get comfortable in what to look out for. Heloisa, coming back to that patient who is getting PRRT and setting that expectations with your patients, keeping the data in mind, what are you expecting with your repeat scans? How frequently are you getting that repeat scan? Which modality? Is it CT scans? Is it PET CT? What is that conversation? And is there any role of chromogranin monitoring here?
I'll start with the easy one. There's no role for chromogranin. We should not be checking that period on the patients for monitoring. That's not appropriate. It's a very insensitive test. So let's forget about chromogranny. And then in terms of which scans to do, all the studies have been with cross-sectional imaging. So we should monitor patients with CTs or MRIs. And then the studies typically did that every 3 months. In my practice, for most of my patients, if they truly have very indolent disease, I will do CT or MRI just before starting treatment to have my baseline. And the first CT or MRI that I'm going to do is about 3 months after completing 4 cycles. If I have a patient that's a little bit more aggressive in terms of the disease that they have, or the burden of disease is a little bit more, then I will do between cycle 2 and cycle 3, I will do day scan. And I think many of my colleagues will do scans in between. Ken, I'd love to see how you do it. But for the very indolent tumors, I tend to wait until the end of the 4 cycles. And I don't do the dotatate PET CTs during or just after treatment. I don't think that's yet established role for that.
We actually perform DOTA scans right after end of treatment, because we can, and we don't have the same costs as in the US, to be honest. Interim, we do the same as you. If there's no clinical reason to suspect progression, or we have a patient where we from the beginning think that this is a borderline great candidate for PRRT, we don't do interim imaging anymore. We have done this for many, many years. We perform PRRT actually for more than 10 years already. And we have stopped this. With the high numbers of patients now being treated, we just cannot do this logistically.
Before we close this conversation, it is important to stress the importance of what you started off with initially, Ken. That is the multidisciplinary approach. It is an extremely important part of the patient care management here, especially when you're tying in surgery, liver-directed therapy, systemic therapy, and also radioligand therapy. And this is all to make sure patients have the best outcome. Ken, any final thoughts or rather clinical takeaways from today's discussion?
MDT is key. There are certain standards we follow, but the truth is that many of the patients, at least in these very specialized centers like ours, and probably also Heloisa's, they are not the ones who follow standard of care. And for this, we need to have these MDT discussions. Where do we add, for example, chemo on top? Where do we add a targeted therapy? Where do we actually go directly to radioembolization? So MDT is key.
Couldn't agree more. And again, this is part of the disease where the treatment does not fit everyone. So you have to, again, maneuver through this complicated course. We have to tailor things accordingly for our patients. Heloisa, any final thoughts or clinical takeaways from your end?
Yeah, thank you. I would definitely agree that MDT is absolutely essential, even from beginning with the pathology, right? Having a overreading the pathology, make sure that the pathology is correct. And then really explaining to patients and to everybody that's caring for the patient that this is really, for most of the patients, a journey. And then it's just about deciding how to sequencing the treatments in a way that makes sense clinically or medically, but also take into account the patient's priorities and goals as well, right? Because thankfully, because these patients live for so long, we really need to see what makes sense at what time of the patient's life and so forth. So really having a good team partnership with the patients and the rest of the groups. And I think it's an exciting time to be a doctor taking care of neuroendocrine tumors. We have so many new treatments coming, and I think PRRT is here to stay. And then I think very soon we will be talking even about retreatment with PRRT, because we now have trials that are even assessing the goal of re-challenging patients with PRRT if they had the initial response to that. So very exciting times for the treatment of neuroendocrine tumors.
Heloisa, I would just echo what you're saying. Patient-shared and informed decision is critical. And the other thing to reiterate is neuroendocrine is not as rare as it was once thought to be. This is something that we're seeing day in, day out in our clinics. Ken, Heloisa, thank you so much for walking us through the current role of targeted radioligand treatment options in neuroendocrine tumors. It is important for us to appreciate available options, how to sequence these options, and importantly, how to manage the side effects that come along with these options. For our listeners, let's go over a quick recap from today's discussion. In today's discussion with Dr. Heloisa Soares, a medical oncologist, and Dr. Ken Herrmann, a nuclear medicine specialist, we had a chance to focus on PRRT, radioligands, as treatment options in neuroendocrine tumors. There are multiple different molecules that will soon be available to us, and this field is moving fast. Now, we also have positive data from COMPETE study for first and second line PRRT in well-differentiated grade 1 or grade 2 tumors, but selecting the right patient and pairing them with the right treatment option is the key.
Yes, Rahul. Multi-D is critical, and referring and partnering up with tertiary or quaternary centers early for us in the community is extremely important. As we heard, data for lutetium dotatalk, when compared to everolimus, has now consolidated the role of PRRT as a second-line therapy for neuroendocrine tumor, but it is also showing promising results in first line as well. And then we also touched on the importance of managing the side effects that come along with our available options here. Thanks for joining us. We are the Oncology Brothers.
If you enjoyed this podcast and want to find out more, then please look for the Oncology Medical Conversation podcast under the account of Core2Ed Medical Education. Also, don't forget to rate this podcast, subscribe to our channel, and share it with your colleagues. Thank you for listening, and see you next time. This podcast is an initiative of Core2Ed and developed by NetConnect, a group of international experts working in the field of neuroendocrine tumors. The views expressed are the personal opinions of the experts, and they do not necessarily represent the views of the experts' organizations or the rest of the NetConnect group. For expert disclosures on any conflict of interest, please visit the Core2Ed website.